Okay, next patient. Chief complaint, pink eye. The generic, non-medical term that can mean anything, but to patients and families, it means one thing. We want antibiotics. And in this case, they may be right. When we talk about the causes of red eye in the ED, we really mean the dangerous things that can cause a painful red eye, like uveitis, iritis, glaucoma. Yes, even children can get glaucoma, preseptal and septal cellulitis, and of course, the dreaded endophthalmitis. We'll leave the discussion of the painful red eye for another day because you're not going to miss those and they deserve their own time. Today, we'll talk about the case that is well within our reach to manage definitively or to mess up royally. The painless but irritating pink eye is usually conjunctivitis, but that's a broad term. What are the ins and outs and causes and pitfalls and special considerations? You may be surprised.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Today we'll take a deeper dive into what we mean when we say conjunctivitis and how to get it right. Traditionally, we want to categorize the presentation, right? Is it viral? Is it bacterial? Is it allergic? I have a little bit of a cliffhanger here for you. And the hint is, what you thought you knew is probably wrong. But it's not your fault. 'Tis a tale been told many a time, but falsely. But since we need to define the myth before we bust it, let's define what is the common knowledge so that we can contrast that with new evidence. Ye old ophthalmologic text of old saith thus: one eye full of pus on the morrow plus, the other goop and drip bacteria. Fever ye seek, on this fire be not meek. And ye old text saith, a scratchy pink eye, clear, not dry, it runs. Its twin within the week hits the virus. Node before the ear, its companion dear. All apologies to the bard and to you, but I think you get my point. The old saying is, bacterial conjunctivitis is fast. It's going to the other eye within a day. It's purulent, and maybe it's even causing fever. Man, if you have a fever with your simple bacterial conjunctivitis, I'm looking further than just your palpebral. And of course, the old dogma of viral conjunctivitis is that it starts as a clear mucus discharge, and within a week or so it will progress to the other eye and it will be accompanied by a preauricular lymph node. Even if this were reliably true, what do you do when the patient comes to you with 1 day of symptoms? Wait a week to see what happens? No. The traditional attempt at distinction between the two has never really been helpful, especially to us in the acute setting. It turns out, despite decades of repetition, there is no evidence in children to support our distinction between bacterial and viral, at least in the acute setting. It's all a myth. There is evidence on the contrary that shows how wrong we are. So you may be withholding antibiotics on faulty grounds. That is, we try to be accurate in our diagnosis and sometimes err on the side of not treating, given the big push to be a good steward of antibiotic use. And that is a good cause, but it may not be the right one for this subject. Why? Because no one can tell you with any evidence basis what signs or symptoms reliably correlate with bacterial versus viral. I know I'm blowing your mind right now. This is why I went to the original literature sources, and I'm sorry to say that there's not much there. Rietveld et al. In the British Medical Journal in 2003 performed a literature review and found that in patients with proven bacterial conjunctivitis by culture, only 60 to 65% had pruritus or a burning sensation. Up to 35% had either non-purulent discharge or no discharge at all. The conclusion is that signs and symptoms of proven bacterial conjunctivitis are not specific or sensitive. The next year, the same group published their own prospective study and found that a combination of 3 signs was a stronger predictor of bacterial conjunctivitis. So the 3 are bilateral matting of the eyelids, lack of itching, and no previous history of conjunctivitis. By the way, this is how good science is done. A literature review or a meta-analysis tells us what is the state of the art, and it makes sense for the authors then to move forward with their own study, having benefited from others' past work. It's a sort of simulated pilot study. Study after study after that shows us that the type of discharge, watery, mucus, or purulent, it's not a strong predictor one way or the other. However, waking up with eyes matted with pus is a stronger predictor of bacterial cause in all studies. So that's probably the one thing that you can take to the bank. Something else on the differential that we should talk about briefly is nasolacrimal duct obstruction. The nasolacrimal ducts are very important, so much so that they begin to develop as early as the 5th week of gestation. That's the same time as your heart and your brain begin to develop. You have the beginnings of nasolacrimal ducts before you even have limb buds. Those start 2 weeks later. Anyway, you can be born with very stenotic nasolacrimal glands and present in the first few weeks of life with epiphora, so excessive tearing, or even blocked or infected ducts. The tip-off here is that there will be discharge from the nasal side of the eye, lots of overflow, but no real, conjunctivitis to speak of. Luckily, most of these cases present a little later in infancy, and so some of the other dangerous diagnoses of conjunctivitis that we'll talk about don't really overlap as much. Instead of trying from the very beginning to decide viral or bacterial, maybe it's better to focus on the distinction between infectious and non-infectious. Outside of the neonatal period, if you think it's infectious and it's very obviously viral, for now, without any evidence of superinfection, or it's obviously bacterial, then great, you can treat that accordingly. And usually the distinction is easier in adolescents and adults. If you're unsure about the cause of the infectious conjunctivitis, in children at least, my advice is to err on the side of treating with antimicrobials with the intention of treating the established infection or, at the very least, preventing the real possibility of an impending superinfection. Our interventional mentality in emergency medicine is different, of course, than the mentality that you might have in clinic. So, in the ED, we don't have the luxury of an ongoing relationship. We have to act with the limited information we have in this small window of time. Not particularly infectious? Maybe it's allergic looking to you? Well, you're going to know because allergic people look allergic. The watery, irritated eyes are just part of the constellation of symptoms, like a constant runny nose. They're itchy, they're scratchy, their throat is involved. The child may or may not have a history of allergies, and atopy is not required. But think about it in the right season. Think about seasonal or environmental allergies. Now, you may see a patient with an established pattern. Think about vernal conjunctivitis. It's also called spring conjunctivitis or vernal keratoconjunctivitis. It's often called morning misery because of the predictable discomfort, mucus discharge, and itching on waking up in the morning. You may see marked papillae when you evert the eye. In vernal keratoconjunctivitis, the buzzwords are preteen and teenage males living in hot climates. We really don't know what causes vernal conjunctivitis, but there's probably an ocular surface hypersensitivity involving mast cells. Treatment is really beyond us in the ED because this is a chronic condition and ophthalmologists use a sophisticated regimen of topical antihistamines and steroids. It's just not what we would prescribe. Some examples are histamines that they may give, like levocapastine or amastine, or mast cell stabilizers like sodium chromoglycate. You may even see them giving topical acetylcysteine to decrease mucus adherence on the cornea. All of these things that I would never prescribe because I just don't use them. Corticosteroids on the eye, we as emergency physicians almost always leave to the ophthalmologist just because they're a big deal to start and they need close follow-up. We really need to keep our specialists in the loop and have them help us to make that decision. You may have a severe case of vernal conjunctivitis that will need the big guns like immunomodulation, cyclosporine, or tacrolimus. Sometimes the papillae are so monstrous in the eyelid that surgical removal is needed. They look like angry cobblestones coming out of the conjunctiva. The summary here is that if you see a young boy who has a chronic, watery, itchy eye with anything that looks abnormal when you evert the eyelid, that did not happen overnight, and he shouldn't just be pushed out the door. We can offer some basic symptomatic relief, but this child needs a non-urgent referral to ophthalmology to get this under control. Luckily, by their 20s, most people grow out of this very irritating problem. My take, if it's clearly allergic, then treat for allergies. If the eye irritation happens to be a minor feature in a constellation of a clear viral syndrome, then great, you have your diagnosis. But what we're talking about here is when someone presents with pretty much only a pink eye. And our question is it bacterial or is it viral? In children, I don't try to split hairs. In children, it's just not worth it. We talked about the accuracy of our signs and symptoms and the potential problems with delay in diagnosis. In adults, it's much more likely to be viral in this first case, and they'll be very vocal about their symptoms, and you'll be able to try to pinpoint a more clear distinction. Children may just suffer in silence. Okay, so you think you have a case of bacterial conjunctivitis. Let's dive a little deeper. You may get a history of matted eyelashes on awakening, or as soon as I wipe, more comes. Bilateral matting of the eyelashes, or gummy eyelids that stick together, there's no itching and no previous history of conjunctivitis, all of that is consistent with a bacterial cause. The eye is mucopurulent. It's goopy, it's injected, it's even chemotic, meaning there's fluid under the conjunctiva. In the cases of bacterial conjunctivitis, everything seems fine except for this ugly, drippy eye. What causes it? Well, dirty fingers touching the face and eyes. That's how you get it. Contaminated fomites in the environment. And also, gross and sad to say, oculogenital contamination, it's a thing. Having said that, the most common causes in adolescents and adults are Staphylococcus, Streptococcus pneumoniae, and Haemophilus influenzae. In children, the most common causes of bacterial conjunctivitis are strep pneumonia, H. flu, and Moraxella. If you do nothing, no treatment, then 60% of bacterial conjunctivitis will resolve on its own within 1 to 2 miserable weeks. But please don't test this out in children. Treatment with antibiotics reduces this to under a week in most cases and really relieves the suffering. To be fair, the evidence of a treatment effect with antibiotics really varies by study. Many of these studies have major design issues. If you see it, treat it. Again, for me, it's not worth splitting hairs. You have a lot of choices here, and you could have a macrolide, for example, like erythromycin. I like to use erythromycin ointment for children who are young and they're not able to tolerate drops. I ask the parents to wash their hands thoroughly, take a 1/4-inch strip of the ointment, wipe it gently on the child's eyelash. The child will blink, blink, blink that in, that wonderful, unctuous bacteria killer, and there's no need to rub it in. Of course, they need to wash their hands afterwards and apply that 3 times daily for a week. Fluoroquinolones are another nice choice for bacterial conjunctivitis. Typically, these are drops like ciprofloxacin or ofloxacin, 1 to 2 drops per eye, 3 times daily for a week. Truthfully, these are my go-to choices. They're effective, they're easy to use, they have a generic version, and they're easy for parents to find in a pharmacy. An older choice that we used to use was sulfacetamide drops or trimethoprim polymyxin B. Now, I stay away from these older generation eye drops because of the higher incidence of allergic reaction. If you see a patient that's been treated recently for bacterial conjunctivitis and it's not better after 2 weeks of treatment, sometimes you'll see people after 4 weeks of treatment, think missed foreign body or chronic bacterial conjunctivitis that needs an ophthalmologic consult. Consider broadening your spectrum to include more enteric bacteria or weirdo things like Moraxella lacunata. No worries, you got this. In the back of your mind, even in small children, consider more nefarious causes of bacterial conjunctivitis, either because it's not better with standard treatment or because, on first presentation, it's hyperacute. What do I mean by hyperacute bacterial conjunctivitis? Severe, purulent discharge and vision complaints over the course of a day. This is not your typical run-of-the-mill bacterial conjunctivitis that slowly stews and simmers and oozes over a few days. Okay, I feel like I'm beating around the bush. Basically, if the eye discharge is so copious and unrelenting that if you saw this in the groin, you would think a sexually transmitted disease, then treat it as such. Gonorrhea is named that way for a reason. The rhea portion literally means pouring out. You may see eyelid swelling, pain on simple examination, and preauricular adenopathy. Neisseria gonorrhoeae loves to chew up the cornea. This is a 4-alarm fire. Not only because the treatment is intense and different, but also because if this is a part of your differential for a child, then we have even bigger fish to fry. Treat with intramuscular or intravenous ceftriaxone for the gonorrhea and azithromycin for possible concurrent chlamydia. We'll talk more about the actual ins and outs of gonorrhea, chlamydia in the eye, but in children, at least in the beginning, think about abuse and trafficking, sadly. So, of course, if we talk about gonorrhea, we have to talk about its traveling partner, chlamydia. Gonorrhea is kind of extra. It's in your face, obvious, purulent, copious, nonstop, dramatic, and acute. Chlamydia is not as attention-seeking as gonorrhea. It's quieter, it's more subtle. You'll see mostly mild, watery mucus discharge. It looks a little worse than your run-of-the-mill viral conjunctivitis. You might see some hyperemia. It's non-relenting. Think about it when you have a conjunctivitis, it's not improving on the standard bacterial regimen. If this is a neonate, he most likely got it from his mother during vaginal delivery. If this is an infant or older child, again, abuse is possible, but genital-ocular contamination from any non-hygienic source is possible. If this is a teenager, you may have to do a pelvic or genital exam, but of course, depending on the situation, the source may not be the patient's own genitals. Okay, I feel like I'm saying genitals way too much on a topic about the eyes. We'll talk more about how to be a private eye detective and what age goes with what pattern of illness in just a moment. Now that we've gone through the nastier versions of conjunctivitis, let's talk about the most common and often the most mild of them, viral conjunctivitis. You know it when you see it. An otherwise healthy person is struggling a little. He or she looks like a wilted flower, runny nose, congested, watery, irritated eyes. We think that about 80% of cases of conjunctivitis in adults will be viral in origin. In children, we're not so sure, but we believe that they're actually either more likely to have bacterial conjunctivitis from an epidemiologic standpoint, or, truthfully, we're just terrible at telling the difference. As I mentioned, our clinical accuracy in distinguishing viral from bacterial in children is a stunning 50%. Of the viruses, many are adenovirus. Adenovirus likes to switch it up. It'll present either two ways, something called pharyngoconjunctival fever or epidemic keratoconjunctivitis. Pretty impressive terms, huh? Seriously, though, this is not anything new to you. Pharyngoconjunctival fever is basically just viral syndrome and conjunctivitis. So fever, pharyngitis, bilateral conjunctivitis, maybe you have some lymph node enlargement, you're feeling miserable, and oh, by the way, the eyes happen to be involved. You got this one, you've seen it many times, you'll feel very comfortable calling this viral conjunctivitis, still having a healthy skepticism that if we're unsure, we can always treat for a superinfection. But it is okay to call it viral conjunctivitis if you feel comfortable with it, and really that's not the main complaint here. Epidemic keratoconjunctivitis is the fancy term for pink eye. This is the presentation where it's mostly just the eye is the problem. It's severe and it's obvious. Watery discharge, hyperemia, injection, and even chemosis. Remember, edema under the conjunctiva. The patient otherwise is well, except for this big, honking pink eye. That's a big bummer. So, viral syndrome is viral syndrome with the side of conjunctivitis, by the way. Pink eye is just that. Really, not much else. It always starts unilateral, but of course, wipe here, wipe there, and both can get it. But there will be a day or so in lag time, so pin down the history to help clarify. One quick word on a terrible viral version. Of course, herpes zoster conjunctivitis. This one won't be a medical mystery. You'll see vesicles on the trigeminal nerve distribution, and be very careful to evaluate the eyes as well. The typical tip-off is the Hutchinson sign, so vesicles at the tip of the nose, which correlates very highly with herpes involvement of the cornea. This person needs an ophthalmologic consult. They need a follow-up. They typically need to be started on acyclovir and topical steroids. All right, we've made the diagnosis of viral conjunctivitis. We're not using antibiotics. It's all about treating symptoms and preventing spread or re-inoculation. Those eyes are irritated, and we can do something about it. But also, it's the time to manage expectations. Patients and families want answers, but more so, they want it fixed now. Of course, there is no definitive cure for viral conjunctivitis, but we can always make people feel better. What would Grandma do? Cold compresses are great. Artificial tears? Great. You can go so far as to prescribe adolescents and adults topical antihistamines if you want to. I don't bother because I'm not convinced that they're worth it. Remember, anytime you have someone put drops in their eyes, they can form an allergy. It can delay diagnosis of something we might be missing, or even encourage them to spread the infection from one eye to the next with an infected dropper. But anyway, the best tincture is time. And your precautionary advice. If the child is not better in a week, then it's time to be seen by the primary care doctor or an ophthalmologist. And of course, wash those hands, and the webs, and the fingertips, and under the nails, and the back of the hands, and the thumbs, and the palms, and the wrists, and rinse well, and maybe wash again, and keep washing. One important subgroup that we have to talk about is neonates. Ophthalmia neonatorum. Conjunctivitis in the neonate. This is the perfect case in which you, as the emergency physician, are the best person to care for this child initially. Oh, your ears perked up just now? Okay, let's do a Yelp review to illustrate. Neonatal conjunctivitis has it all. Not too rare, the stakes are high, and you have to make the decision to go full bore based on your evaluation alone. 1 star. Would not recommend. You see where I'm going here. When we have a neonate of only a few days of life, you have to think about what type of infection he could have and what ramifications that diagnosis may have. As we remember, any infection in a less than 28-day-old is a big deal. So let's review what days of life each bug shows up in. We think of the presentation in terms of within 24 hours of birth, 1 to 2 days of birth, the first week, and the first 2 weeks. These are all very generic timelines, and there's definitely overlap, but we need something to anchor our thoughts on. A newborn baby has red, injected, irritated conjunctiva within the first 24 hours. He typically has chemical conjunctivitis. How? What? Why? What's going on here? Well, one word: tradition. In the late 1800s, 1 in 10 newborns developed conjunctivitis soon after birth, and 3% of those became blind because of it. Dr. Albert Neisser, a German physician, discovered that often gonorrhea was the culprit. He suggested a solution of silver nitrate topically to treat the Neisseria gonorrhoeae in infected babies. Soon after, another German physician, Karl Krede, did some knowledge translation and simply started giving this solution to all babies to prevent infection. He was a believer. Of course, there were no IRBs or randomized control trials back then, but before Dr. Krede started his prophylactic treatment, he personally would have had 30 to 35 cases of gonorrheal conjunctivitis in the newborns that he took care of. Within the first 6 months of starting his own protocol of giving eye drops to all babies, he had only 1 case in that time frame in the 6 months. It's a remarkable decrease in morbidity. Fast forward to modern medicine, and a few things have changed. Epidemiology of disease and options for treatment. We are detecting and treating sexually transmitted diseases in mothers before birth, thankfully. Also, chlamydia has become more popular. Also, silver nitrate was the best thing back then, but it's prone, of course, to eliciting a strong allergic reaction. So that's gone by the wayside, and now enter erythromycin ointment. It's subsequently been found to prevent staph, strep, even chlamydia and gonorrhea. It's a real Swiss Army knife of ointments, prophylactically speaking. The incidence of gonorrhea prenatally has been drastically reduced. And of course, it makes sense to have some kind of gonorrheal or chlamydial infection from vaginal births rather than cesarean sections. But all of these recommendations about treatment prophylactically, they'll vary by locale. The U.S. Preventative Services Task Force recommends 0.5% erythromycin ointment within 24 hours of birth for all babies regardless. The American Academy of Pediatrics has a more nuanced guidance depending on local rates of infection, and some countries have dropped it altogether. That's a big intro to say that you may see a child within the first 24 hours who starts to develop conjunctivitis. It's almost always conjunctivitis, but find out what happened. Did they actually get anything in their eyes? Although erythromycin has a lower rate of allergic reactions than pretty much any other historical agent, it's still possible. Now, with newborns being discharged very early, you may see a 1 to 2 day old baby with a rip-roaring conjunctivitis in both eyes. But remember, and this is important, it matters most when the symptoms began after birth, not when you're finally seeing the patient. So if this is an eye irritation that the child started to have in hospital and now you're seeing it worse a few days later, then you probably have your diagnosis here. Nothing to do other than cold compresses as tolerated and a lot of observation and time, follow-up. So within 24 hours, it's chemical, but to be honest, it's not very common anymore. And unless it's totally obvious that that's the case, I would put that under the category of, interesting, but not as helpful. Now we get to the dangerous stuff. If the conjunctivitis develops 1 to 2 days after birth, be very concerned about Neisseria gonorrhoeae. Gonorrhea is a hyperacute infection. As they say, when you got it, you got it. Just don't give it to anyone else. Gonorrhea conjunctivitis, thankfully now, only accounts for 1% of ophthalmia neonatorum, mostly because of just good prenatal care. But the rate is up to 40% in untreated mothers and those who didn't have very good prenatal care. So a good history about the extent of the prenatal care, when the child was born, how the child was born, all of those are very important. Gonorrhea conjunctivitis presents with chemosis, edema of the eyelids, and copious purulent discharge. That eye is angry. It's not subtle, and it ain't pretty. You may even see a little blood tinge to the output. Neisseria gonorrhea does nasty things like penetrate intact corneal epithelium, causing ulceration and perforation. Panophthalmitis and disseminated infections are all well documented, and it's a predictable sequela. This is a real emergency. Treatment is ceftriaxone, IV or IM, admission, serial irrigations of the eye, and observation for possible disseminated infection. And if you're giving an antibiotic IV to a neonate, what about that LP? I'm building up suspense purposefully. Don't worry, we'll get there. Okay, within 24 hours, chemical. Within 1 to 2 days, gonorrheal. Within approximately 1 to 2 weeks, give or take, chlamydia. This makes sense since chlamydia, as we mentioned, is a bit more tame and slow to get crazy. Chlamydial conjunctivitis presents 1 to 2 weeks after birth with scant, watery discharge. Maybe it's a little bit more mucus-like. There might be a little bit more chemosis. A pseudomembrane may form. It happens when an inflammatory exudate that's rich in fibrin coagulates on the conjunctiva, and it looks like a white film that covers the conjunctiva. You can even peel it off with a cotton swab, and you'll see the underlying epithelium with maybe some scant bleeding underneath. It's truly gross, like a sci-fi alien reptile gross. Chlamydia takes time, but it does it right. It can cause all kinds of problems like preseptal cellulitis, otitis, pneumonitis. Treatment includes topical erythromycin ointment and oral erythromycin 25 to 50 milligrams per kilogram per day, divided into 4 doses for 2 weeks to prevent recurrence and secondary pneumonitis. So, within 24 hours of birth, chemical. 1 to 2 days of birth, gonorrhea. 1 to 2 weeks of birth, chlamydia. And that's all great, but there is that overlap. Gonorrhea can rear its ugly head up to a month after birth. Chlamydia is the same. It's very frustrating and scary. When I see a neonate with conjunctivitis in the ED, for the most part, it's usually a child who's about 3 days old to about 7 to 10 days. And in many cases, I feel a little stuck. That's exactly in the sweet spot of the overlap. And very rarely is it very obviously one thing or the other. You'll see different approaches in different sources, but I'm here to pull the pseudomembrane from your eyes. There's no strong evidence basis for initial emergency evaluation. We just don't have the best guidance. And in the absence of evidence, we have to fall back on our principles and what we do know. We do know that there's overlap of dangerous disease here, such as gonorrhea, which will require admission, and chlamydia, which, if you somehow magically knew for sure, you would hear the advice to start treatment as an outpatient. Okay, well, how do we balance these and how do we figure this out? We do know that we aren't getting back any tests or cultures or anything of any help when we see that baby. We also know that the neonate has a very leaky blood-brain barrier, and any serious bacterial infection in a neonate requires a full sepsis workup. You can see where I'm going with this one too. Now, the following is my opinion, but it's based on the best science and logic that I can offer you, but you can hear other approaches, and I respect that. But this is how I make the tough call. Acute neonatal conjunctivitis should be treated as gonococcal until proven otherwise. I'm not talking about a little irritation 24 hours after birth or something that is very clearly viral 3 weeks after without a fever. I'm talking about the watery mucus or purulent discharge coming out of one eye in an infant less than a month old. Assume it's gonorrhea until proven otherwise. Babies usually contract this through vaginal delivery, but untreated parents can inoculate the neonate after birth, just not knowing. Again, in the absence of high-quality, rigorous studies, we have to use our common sense and adhere to our core concepts and principles. Since any serious bacterial illness in a neonate can become bloodborne, we have to assume that it's going to become bloodborne. And for this reason, we often perform lumbar puncture on febrile neonates without a source. We don't know. Oftentimes it ends up being nothing, but we don't take that chance. We have to be sure that there is no involvement in that CSF because we want to give antibiotics. And the treatment and duration is different whether the infection is local, bloodborne, or already meningeal. Now, we always fear just throwing out some antibiotics at a neonate without interrogating the CSF for that reason. The danger is that if you give a dose or duration of an antibiotic that's not sufficient in treating an infection in the CSF, you get partial treatment, a delay in diagnosis because it's hard to tell in the neonates. They just don't do very much other than eat, sleep, poop, and pee, and they may have permanent sequelae if we miss it. So, except for topical antibiotics, the general rule is that if you're treating a neonate with IV antibiotics, even if you think you know the extent of the infection, whatever it is, you need to verify no CSF involvement at the time of initiation of antibiotics, or risk the very real consequences of delayed diagnosis and neurologic complications. So that means blood cultures, eye cultures, labs, LP, IV antibiotics, and admit. So, goopy eye in the neonate? If it's not obviously nothing, you assume it's everything. To summarize where we are right now, first, is it a neonate or is it not? If yes, assume infectious until proven otherwise, and assume dangerous infection until proven otherwise. In infants, toddlers, and children, you have more of a luxury of some breathing room. You can ponder whether you feel this is infectious or not, or maybe it's an allergy, it's a local reaction, you're going to look for foreign body, you're going to do your really good H&P. Or you may decide this is an infection. If it's infectious, err on the side of treatment in children for either a current bacterial cause that is just starting to brew or an impending bacterial superinfection. That is the core of what we need to know and what we need to do. But, I'm always looking out for you. I want to give you a little extra spin on it. So a few miscellaneous things. Let's go rapid fire. Contact lens wearers with conjunctivitis. These will typically be adolescents and adults. They need to get that contact lens out now, and they need to wear glasses until the infection is cleared. You're going to treat it. These patients are at high risk for ulceration, pseudomonas, and even fungal infections. If the patient is doing relatively well, you can prescribe something like ciprofloxacin, no contact use, and ophtho close follow-up. Foreign body. This should always be on our differential diagnosis. Get a good history. Babies and young children should get a Woods lamp fluorescein test to look to see if there's a corneal abrasion. Evert the eyelid. Don't miss a small retained foreign body causing the unilateral eye irritation. Conjunctivitis not responding to standard care. A few things. Either it's a recurrent auto-inoculation, there's poor adherence to the plan, or it's not bacteria. The emergency department has open doors to the world, and you'll see people from all walks of life and all places. What about TB? Tuberculosis gets around, and children can manifest TB with focal infections. If someone is on the proper therapy and there is no improvement, you may want to refer them to an ophthalmologist to consider mycoplasma. You might see a mild conjunctivitis, and if you look closely, the bulbar conjunctiva may have a nodular appearance. There's some lumpy bumpiness under the conjunctiva. Do a great lymph node exam. If you're concerned, these patients need a biopsy and treatment for 6 months. Also in the child with comorbidities or none, ongoing infectious conjunctivitis, not responding to standard care, they may have a fungal infection. Just keep it in the back of the mind. It's not very common at all, but unfortunately, some people use the emergency department as their only source of primary care, or they just really like us a lot. So they may have that fractured care where they just keep coming in for the same problem. And if we don't get a really good history and physical, we may just be repeating the same mistakes. They may actually have a fungal infection. So get your friendly neighborhood ophthalmologist on board. Testing for conjunctivitis. Now, most of the time, this is a satisfying diagnosis. It's mostly clinical, and no testing is really required. Just your really good H&P skills and remembering the concepts we talked about. With 2 notable exceptions. We talked about the neonate, but what about the teenager with hyperacute conjunctivitis that looks goopy and red and swollen? Think about gonorrhea. Again, if it looked like it could come from the groin, then it might have. Treat it before you can confirm. In neonates, of course, with gonorrhea, that's a full septic workup. Send those cultures, blood, and also in the eye. In teenagers, it's treatment with ceftriaxone and sending a discharge culture. A gram stain of the eye purulent discharge will show gram-negative intracellular diplococci if it's gonorrhea. To culture whatever discharge you're able to get, make sure you use the Neisseria selective medium called Thayer-Martin, or whatever your local lab recommends. Give them a call, find out before you close that loop. Culture them, mark any site that looks suspicious, including the oropharyngeal site, the rectal site, or really anywhere else. Okay, just to hammer it into our heads, neonatal conjunctivitis is serious business and assume the worst. In general, within 24 hours of birth, chemical, 1 to 2 days of birth, gonorrhea, 1 to 2 weeks of birth, chlamydia. Older children, determine infectious or not. If infectious, err on the side of treatment. Bacterial conjunctivitis is much more common in children than in adults, and viral conjunctivitis is much more common in adults than children. Signs and symptoms are not ironclad, but waking up in the morning with eyes matted down and no itching, that makes it more likely bacterial. Viral conjunctivitis is usually an afterthought to the whole viral syndrome. Otherwise, err on the side for treating for bacteria. Hyperacute conjunctivitis is gonorrhea until proven otherwise. And wash your hands, people. We'll close with one last Shakespeare quote. The miserable have no other medicine, but only hope. Luckily for your patients, they also have you and your new knowledge of the scourge of the conjunctiva. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.